Hi guys, welcome to FastCoder 21 Medical Coding YouTube channel. As we have received numerous requests from our subscribers regarding emergency department coding, we have completed all emergency department coding sessions including infusion and injections and most common CPT procedures in the emergency department you can find in our YouTube channel. So today's our topic is most important and common emergency department interview questions and answers. So in order to code emergency department, we need to know what is the meaning of emergency department. So an emergency department, also known as accident and emergency department, usually we can see A and E, emergency room or casualty department, is a medical treatment facility specializing in emergency medicine, the acute care of patients who present with or without prior appointment, either by their own means or by that of an ambulance. ED services are generally available 24 into 7. So basically, in order to understand emergency department does not need any appointment. You can go directly by walk-in and you can admit. Based on your condition, emergency department physician will treat you. And these emergency departments are available 24/7. So you can go anytime in a day. Next question. How many types of emergency department do we have? Usually we have two types of emergency department. So type A and type B. So next question, how do we define type A and type B emergency department? So type A means a provider based emergency department must meet the following requirement. So type A emergency department is licensed by the state in which it is located under applicable state law as an emergency room or emergency department and be open 24 hours a day, 7 days a week. So type A is our regular emergency department. These are available for 24 hours a day and 7 days a week. So which will work under state licensed practice. So what is meant by type B emergency department? Type B emergency department, a provider based emergency department must meet the following requirements. It is licensed by the state in which it is located under applicable state law as an emergency room or emergency department and open less than 24 hours a day, 7 days a week. So basically only availability of emergency department services is the difference here. So type A is available or open 24 hours a day and 7 days a week, as well as type B is available less than 24 hours a day and 7 days a week. So next question, tell me the difference between inpatient and outpatient coding guidelines. So inpatient and outpatient services are coded according to the guidelines regarding the place of service and duration. Usually inpatient, usually these are hospitals. Here 24 hours, more than 24 hours stay will needed for inpatient hospitals, as well as outpatient clinics, offices, ambulatory surgery center, same day services we will get in outpatient services. Do repeat. Mm. So inpatient facility is coded based on the entire patient chart to determine a final diagnosis, present and admission factors, and CCs or MCCs as opposed to the clinics which are coded based on encounter reason for visit. So in order to code inpatient services, we need to check the whole chart in order to determine a final diagnosis. And inpatient is dependent present and admission factors also, and as well as we need to use or consider CCs or MCCs for inpatient hospitals. Whereas clinics, we no need to consider all these things like CCs or MCCs. So in clinics, we will code based on encounter, which is reason for visit of the patient. So IP facility coding allows for rule out diagnosis where OP and prophy require a symptom or final diagnosis that has been confirmed by the physician. So IP procedures are coded with ICD-10 PCS and OP prophy coded with CPT. So basically, in IP setting or inpatient setting, we can code the conditions which are having rule out diagnosis. So whereas in OP facility or prophy, we can't code rule out diagnosis. In order to code inpatient procedures, we will use ICD-10 PCS coding system. So whereas in outpatient settings, we will use CPT procedures or coding system. Next question. How do you describe the difference between facility and prophy coding? So facility is for nurses services. So employees of the hospital directly and supplies. So mostly facilities depends on the services and supplies. So whereas prophy is for the physician services like evaluation management, surgical procedure, consultations. The physician is not hospital employee but is providing services at that location. So basically facility is for services and supplies. Prophy is for the physician services, as physician is not an employee of that hospital. Next question. What is a modifier to you? A modifier describes circumstances applicable to code but not changing the code's definition. So based on the situation or payer requirements, we need to add the modifier to CPT code. So this modifier will not change the code description or definition, but it will provide additional information regarding that procedure. A modifier changes how a procedure is considered for payment, such as a return to the OR during an otherwise unpayable global period, who provided the procedure, where on the body the procedure was performed, and in some cases with epics modifiers, the reason for the procedures. So we have complete sessions related to modifiers in our Fast Coder 21 YouTube channel. You can check our Fast Coder 21 channel to find NCCA modifiers and as well as edits. So basically we have different types of modifiers. Like we have payment modifiers, laterality modifiers, like usually we'll call it as anatomical modifier, and few are informational modifiers. The informational modifiers will not impact the revenue, but it will provide extra information to the payers. Next question. Where do you use modifiers? So usually we will use modifiers in order to append with CPT and HCPCS codes. So next question, who is a qualified healthcare professional? Usually we'll call it as QHP. So nurse practitioners and physician assistants, physician extenders who are licensed to practice medicine. So nurse practitioners and physician assistants and physician extenders all are qualified as qualified healthcare professionals. Next question, how is a self-limited or minor problem defined? So, a problem that runs a definite and prescribed course is transient in nature and is not likely to permanently alter health status. So, self-limited or minor means it is not in serious condition. Transient means it is in like less severe condition. It may not change the health status of the patient permanently. Next question. How is a stable chronic illness defined? A problem with an expected duration of at least a year or until the death of the patient. So basically, chronic illness is a expected duration of chronic illness is at least 1 year or until the death of the patient. So these chronic conditions will exist more than 1 year or until the death of the patient. So for the purpose of defining chronicity, conditions are treated as chronic whether or not stage or severity changes. So, stable for the purpose of categorizing medical decision making is defined by the specific treatment goals for an individual patient. So, this stable word is defined as it is based on the individual patient. Some patients may have still condition, a chronic condition, but few patients might have stable chronic conditions. Stable means they are not affecting the patient's health currently. So, they are not creating any severe illness to a patient. So a patient who is not at their treatment goal is not stable. So in order to define stable, patients needs to have the treatment goal. So even if the condition has not changed and there is no short-term threat to life or function. So for example, a patient with persistently poorly controlled blood pressure for whom better control is a good goal is not stable, even if the pressures are not changing and the patient is asymptomatic. The, the risk of morbidity without treatment is significant. So if a patient has poorly controlled blood pressure, it is not at a treatment goal. So it is not stable. Even if the pressures are not changing and the patient is asymptomatic. So blood pressure needs to be constant and it must not be changed. Next question. How is an acute uncomplicated illness or injury defined? So a recent or new short-term problem with low risk of morbidity for which treatment is considered. So basically it is a recent or short-term problem with low risk of morbidity for which treatment is considered. So what is meant by morbidity? It is like suffering from the disease or disorders. So there is little to no risk of mortality with treatment and fully recovery without functional impairment is expected. So if it has an acute condition, there is no risk for mortality with treatment and the patient will recover easily. So a problem that is normally self-limited or minor but is not resolving consistent with a definite and prescribed course is an acute uncomplicated illness. So basically, acute conditions are not life-threatening. We will treat those acute conditions with proper treatment. So next question, how is chronic illness with exacerbation, progression or side effects of treatment defined? So a chronic illness that is acutely worsening, poorly controlled or progressing with an intent to control progression and requiring additional supportive care or requiring attention to treatment for side effects, but that does not require consideration of hospital level of care. So for example, if you take blood sugar like diabetes, so few patients may have poorly controlled diabetes, but but those patients no need to admit in a hospital. They will control their blood sugar using the home treatment, which will come under chronic illness with exacerbation or progression or side effects of treatment. Next question. What are clinical examples of an undiagnosed new problem with uncertain prognosis? So a problem in the differential diagnosis that represents a condition likely to result in high risk of morbidity without treatment. So, undiagnosed new problem is a problem in the differential diagnosis that represent a condition likely to result in high risk of morbidity without treatment. So, for undiagnosed new problem, we need to take the treatment. Otherwise, disease or disorder may for high risk for disease or disorder without treatment. Next question: how is each unique source defined? Answer: an external physician or other QHB, QHB means qualified health provider, who is or practitioner who is not in the same group practice or is of a different specialty or subspecialty. So in order to qualify for each unique source, the physician must not be from the same facility or same group or same specialty. So this includes licensed professionals who are practicing independently. So independent physicians will also come under each unique source. So they need not to comes under group practice or that facility. So the individual may also be a facility or organizational provider such as from a hospital, nursing facility or home health care agency. Next question. Do we receive credit for each unique test? We either order or provide the interpretation or report, past or present. Any test with a CPT code, current or past, for which you received separate payment does not count in this category. So if we have any CPT code, which we have received the payment, which will not come under this category. Next question. Who qualifies as an independent historian? So an individual, parent, guardian, surrogate, spouse, witness who provides a history in addition to a history provided by the patient who is unable to provide complete or reliable history or because a confirmatory history is judged to be necessary. In the case where there may be conflict or poor communication between multiple historians and more than one historian is needed, the independent historian requirement is met. So basically, independent historian is a person who can provide the information regarding the patient along with the patient. Next question. What constitutes moderate in category 1? Is it 3 out of 4 possible bullets or 3 from any combination in this category? So answer, the requirements in this category can be met anyway as long as there are 3. All 3 can be ordering tests or there can be 2 order tests and 1 review of the test result. So there is a lot of flexibility to meet requirements in this category. As long as there are at least 3 elements, like we usually will call it as bullet points performed, regardless of which specific ones are performed, the requirements are met. Next question. Does a letter to the referring source count for discussion of management or test interpretation with external physician, qualified health professional or appropriate source? No, to qualified discussion requires two-way communication. Next question. How is appropriate source for the purpose of the discussion of management defined? So answer, an appropriate source includes professionals who are not healthcare professionals but may be involved in the management of the patients like lawyer, payroll officer, case manager and a teacher. It does not include discussion with family or informal caregivers. So here lawyer, payroll officer, case manager and teacher all are comes under appropriate source for the purpose of discussion of the management of the patient. So next question, what is minor and major surgery definition? According to Medicare, a major surgery has a global period of 90 days and a minor surgery has a global period of either 10 days or 0 days. Next question, what are social determinants of health? Economic and social conditions that influence the health of people and communities. Examples may include food or housing insecurity. Next question, what are the three key components in 99283? So answer, expanded problem focused history, expanded problem focused examination, moderate complexity medical decision making. So can you tell me few examples for the code 99281? So usually insect bites, tuberculosis test, routine wound check, routine blood pressure checks, all comes under 99281 which are less severe. Next question, what is HCPCS? Usually we'll call it as HICPICS. So HICPICS stands for Healthcare Common Procedural Coding System. It consists of CPT codes known as Level 1 HICPICS codes and HICPICS Level 2 codes that represent hospital supplies, drugs, dental codes among all. So basically our 5-digit numerical CPT codes come under Level 1 HICPICS codes as supplies and drugs and dental codes come under HICPICS Level 2 codes. Next question, what are E&M codes? Answer, the CPT codes which describe physician-patient encounters are often referred to as evaluation and management codes. Next question, what are emergency department service E&M codes? So usually codes from this section are used by a hospital-based departments that are open 24 hours a day. They are often combined with critical care services. For emergency department, we will use 99281 series to 99285. So next question, what are critical care services codes? So codes from this section are used to report the length of time the physician spends providing care to a critically ill patient. These codes come under a series 99291 and 99292. Basically, for the critically ill patient, we will use critical care service codes like 99291 and 99292. So next question, can you tell me few examples for critical care services? So what are the criteria in order to code for critical care here? So multiple trauma and head injury with loss of consciousness, burns threatening to life or limb, coma of all etiologies except hypoglycemic, shock of all types, septic, cardiogenic, spinal, hypovolemic, anaphylactic. So all these type of services comes under critical care services. So basically whenever the patient has these conditions, physician needs to consider it as a serious condition and he needs to provide critical care services. So here, what is the next question? What is the minimum time required to report critical care services? Usually, in order to code critical care services, we need to have minimum of 30 minutes. So if it is less than 30 minutes, we can't code them. Next one, what are the services included in critical care? So usually we have vascular access procedures and interpretation of chest x-rays, gastric intubation, temporary transcutaneous pacing, so interpretation of cardiac output, ventilator management, pulse oximetry, information stored in computers. So if you see all these procedures are very complicated. So normal purpose in order to code 99281 to 99285, these procedures are not needed. For in order to code in critical care, these services are included. So if the physician performs any type of these procedures, we can consider it as a critical care service and we need to code 99291 to 99292. Next question, how do you convert laceration dimensions to centimeter? So usually based on guidelines in CPT books, we have lacerations defined in centimeter. So what happens if what do you do if the physician mentions in inches? So for example, if physician mentions 1 inch laceration, how do we code? We need to consider it as 2.54 centimeter. So if the physician mentions 10 millimeter, we need to consider it as 1 cm. So next question, how do you code foreign body removal? So basically we should not code when foreign body removal by forceps. So don't code foreign body removal without documentation of incision. If part of the foreign body is removed, the foreign body removal code should be reported with a 52 modifier. So basically, if the physician removes foreign body using the forceps, we can't consider it as a foreign body removal. So and also, if the physician does not create any incision, we can't quote foreign body removal. So in example, if the physician removed only part of the foreign body, we need to add 52 modifier, which is reduced services modifier. Next question, how do you code burns? We need to check the documentation to find whether the provider must clearly indicated that he or she is doing the debridement or personally applying the silverdine dressing. So these are the requirement in order to code the burns. Guys, we have separate session for emergency department, CPT common procedures. So after watching this session, you can watch that session also. That session is extensive or and elaborated session for emergency department coding common CPT procedures. Here you will learn only definitions, but in that session you can learn how does the physician will perform those procedures. So next question, what is an IVP? An IV administration of a therapeutic, prophylactic or diagnostic drug. B. An infusion that runs for 15 minutes or less. C. An infusion without documentation of a stop or continuing time. So basically, while infusions and injections, we will consider IVP as if it is 15 minutes or less, and if you don't find any starting time or stopping time, we can consider it as a IVP. So next question, what is cardioversion? So cardioversion is a medical procedure by which an abnormally fast heart rate or other cardiac arrhythmia is converted to a normal rhythm using electricity. Usually we'll call it a shock. So next question, what is trigger point injection? Answer, trigger point injection may be an option for treating pain in some patients. So trigger point injection is a procedure used to treat painful areas of muscle that contain trigger points or knots of muscle that form when muscles do not relax. So basically trigger point injections are used for the muscle problem. So in order to relieve trigger point, so physician will inject injection into the muscles. How do you code infusion and hydration? If infusion and hydration are being infused at the same time, we need to code only for the infusion. So we will not code the hydration. So how do you code dislocation code? So answer, append 25 modifier to ENDM if dislocation code has less than 10-day global period, and 57 modifier if dislocation code has 90-day global period. Next, can we add 25 modifier to smoking cessation counseling? Yes, we need to add 25 modifier to smoking cessation counseling. Next question, what is an open and closed fracture? So open fracture or dislocation site opened surgically by physician and visualized, typically not performed in ED. So what happens in open fracture? Physician may create incision and he will open the fracture site. So what about in ED, usually physician will not perform open fractures. In ED, usually we will have closed fracture treatment. So what is a closed fracture here? Fracture or dislocation site not opened surgically describes care with and without manipulation. So in order to treat using closed fracture, so physician will may use manipulation or he may not use manipulation. So next question, what is CPR? CPR means cardiopulmonary resuscitation. And next question, how many types of splints are available? We have two types of splints. One is static splint, keep an injury immobilized to be used as the default type if static dynamic is not documented, and dynamic splint allow for movement. So basically static splints were immobilized. They will not move the injury part, and dynamic splints they will provide some movement for the injuries or injury part. So what is the difference between simple and complex IND? So a simple IND includes drainage of the pus or purulence from the cyst or abscess. The physician leaves the incision open to drain on its own, allowing for healing with normal wound care. Usually we will call it as incision and drainage of simple. And what about complex? A complex IND includes placement of drainage tube to allow for continuous drainage or packing to facilitate healing. In certain cases, tissue excision, primary closure, and a jet plasty may be required. So, in simple IND, physician will just open the abscess site and he will keep it as it is. But in order to code complex IND, physician needs to put the drainage tube or physician needs to keep package inside the abscess site. So what is cerumen impaction? Cerumen can build up in the air canal, which may be lead to symptoms of discomfort, dizziness, and impacted hearing, for which patient seeks medical care. Next question. If the earwax is not impacted, can you code separate CPT code for cerumen impaction? No. If the earwax is not impacted, we can't code for separate CPT code for cerumen impaction removal, as removal is included in the documented evaluation and management services reported and may not be separately billed. So in order to code cerumen impaction code, we need to check whether physician has mentioned impacted or not. Next question, what is epistaxis? Usually epistaxis is nosebleed. So what is arthrocentesis? Why do we perform arthrocentesis? So basically arthrocentesis is the process of using a syringe to collect synovial fluid from a joint capsule. It is also known as joint aspiration. So, so this procedure is used in the diagnosis of gout, arthritis, and synovial infection such as septic arthritis. ED coding guidelines use the codes for without ultrasound guidance. So, in order to code in emergency department for arthosynthesis, we can use the code which are having ultrasound guidance, which are not having ultrasound guidance, as we have orthocentesis codes with guidance or without guidance. So here in the emergency department, we need to use the without guidance orthocentesis codes. You can check our common CPT procedures in the emergency department section, so you can get good idea about orthosynthesis. Next question, what are the layers of skin? So while in order to code excision of lesions, you need to know the layers of the skin. So here epidermis, dermis, subcutaneous tissue, fascia, subfacial, intramuscular or submuscular. Why means our CPT codes for excision are depends on epidermis, dermis, subcutaneous one level, and under subcutaneous level, fascia, subfacial, intramuscular, submuscular, which all comes under like soft tissue tumor resections, like soft tissue excisions. So these three comes under normal. So these four comes under soft tissue excisions. Next question, what is an intermediate repair? So an intermediate repair is defined in CPT as the layered closure of one or more of the deeper layers of subcutaneous tissue and superficial fascia in order to the simple repair, and includes single layer closure of heavily contaminated wounds that require extensive cleaning and removal of particulate matter. The use of two types of suture material is not necessarily indicative of intermediate repair. So if the use of two types of suture material is documented, consult with the physician to confirm the type of repair performed. So in order to code intermediate repair, physician needs to perform the layer repair of the laceration or wound. Next question, how do you code multiple wound repairs? So when multiple wounds are repaired, we need to add together the lengths of those in the same classification, like simple, intermediate or complex, that are also in the same subcategory of code. So in order to code multiple wounds, we can combine the repair codes in simple, and we can combine all the repair codes in intermediate, or we can combine all the repair codes in complex, but we can't combine simple or intermediate. So next question, how do we code simple and complex repair? When more than one classification of wound is repaired, they are reported based on severity. For example, if the patient has complex repair on the leg and simple repair on the hand, we need to code leg repair, which is complex repair first, followed by simple repair of the hand. So next question, what is a ET tube? Usually we'll call it as endotracheal tube. So ET tube means an endotracheal tube. Endotracheal intubation, usually simply referred to as an intubation, is the placement of a flexible plastic tube into the trachea to maintain an open area or to serve as a conduit through which to administer certain drugs. So what is the purpose of ET tube? In order to open the patient's airway and in order to administer few drugs, physician may insert ET tube. So next question, what is the use of venous access devices? So patients who require frequent access to the bloodstream, administration of medications, administration of fluids and nutritional compounds, transfusion of blood products, multiple blood draws for diagnostics. In order to acquire all these services, physician will use venous access device. Next question, what are venous access device time duration? CVC and port are long-term purpose. Peak line is up to 1 year. So CVC means central venous catheter and port are for long-term purpose. So if the physician wants to keep the venous access device for up to 1 year, he will use PICC line. PICC line means peripherally inserted central venous catheter. So what is PICC line? Peripherally inserted central venous catheter. Next question, what is tunneled and non-tunneled catheter? Non-tunnel means percutaneously inserted for short-term use. It is generally used to infuse medications, fluids, blood products, and parenteral nutrition and to take blood draws. Tunnel means tunnel is more severe than the non-tunnel. Here, physician will keep the catheter inside the skin. So if the physician wants to keep the catheter for long term, he will provide the tunneled care or tunneled catheter. So next question, what are the criteria to in order to code central venous access? So we need to check location of the tip of the catheter. So whether subcliniar or brachiocephalic or iliac veins, superior or inferior vena cava or right apium. So we need to check the location of the tip of catheter, and we need to check insertion or puncture location. So means where the physician has starting to insert the catheter. And next one is age of the patient and tunneled or non-tunneled or port or pump. Next question, what is moderate conscious sedation? Moderate conscious sedation is a drug-induced depression of consciousness. So what is lumbar puncture? Lumbar puncture is a procedure that is often performed in the emergency department to obtain information about the cerebrospinal fluid. So next question, what is a nerve block? So injecting an anesthetic close to the nerves that supply a part of the body in order to produce insensibility to that body area. So nerve blocks generally for treatment purpose also physician will use nerve block, while some few surgeries also physician will use nerve blocks in order to reduce or prevent the pain. Next question, what is paracentesis? So paracentesis is a procedure in which a needle or catheter is inserted into the peritoneal cavity to obtain acidic fluid for diagnostic or therapeutic purposes. So next question, can you code bladder irrigation and Foley catheter insertion at same time performed in the same session? We can't code both at same time. When bladder irrigation and Foley catheter insertion are performed on the same patients in the same session, we need to code only for the Foley catheter insertion. So next question, what is nebulization? Nebulization is the process of medication administration via inhalation. It utilizes a nebulizer which transport medication to the lungs by means of mist inhalation. Next question, what is new and established patients in ED? So basically there is no difference in the ED regarding new or established patients. Next question, what is the place of service code for ED? Usually it is 23. Next question, what is SOAP? Usually we will find the word SOAP format. So here S means subject to, O means object to, A means assessment, P means plan. So usually physicians will create based on SOAP format. Next question, what is chief complaint? The chief complaint is a concise statement that describes symptoms, problem, condition, diagnosis, or reason for the patient's encounter. So the reason for patient's encounter mainly constitutes chief complaint. Next question, how many elements are there in HPA? We have 8 elements in HPA. So what is ROS? ROS is review of systems. What is the difference between 1995 and 1997 guidelines? In 1995 guidelines, in history only elements are counted. In examination somewhat subjective. In medical decision making it is common for both 1995 and 1997. Whereas in 1997 guideline, states of chronic conditions may substitute for ailments. Highly depend examination bullets. So 97 guidelines are more complex than 95 guidelines. Next question. Do ED E&M codes differentiate between new and established patients? So basically in ED, there is no differentiation or difference between new and established patient, as ED services will provide emergency services. Next question. When can you caveat the entire history? Answer. You can give a comprehensive history when the patient is intubated, unconscious, or unable to give the physician history. So based on the patient's condition or patient is intubated unconsciousness or unable to give the physician history, we can use the caveat. If there is documentation that a family member is present, then look for a notation that they are unable to provide further historical information. In those situations, we can caveat the history. Next question. Can someone record the patient's history other than the physician? The ROS and PFSH may be recorded by ancillary staff, residents or student or on a from form completed by the patient, but the document mainly HPI, physical exam and assessment needs to be confirmed by the physician. Assessment is very essential. It must be provided by the physician. Next question. So how do you calculate head traumatic, atraumatic, normocephalic? Usually this sentence comes under musculoskeletal examination. Next question. If DNR is listed on the patient record that is in the hospital for an extended time, would the level of risk in the MDM section be considered high throughout the hospitalization, or would it only be counted if it's specifically mentioned in that encounter? You would only count the high risk part of MDM on the day that they initially reviewed the DNR order. For the remainder of the stay, either the circumstance must be evaluated to determine high risk or the MD needs to review the DNR status again. DNR means do not resuscitate. Resuscitate. Next question. What is the difference between independent visualization of image, tracing or specimen itself, and review and or order of test in radiology section of CPT in complex table B? So in order to get credit for the visualization of the provider must document that he or she viewed the CT, X-ray or MRI film. So it must not be assumed that the film was viewed. It must be clearly stated within the documentation in order to take it as a point while coding E&M. Next question. What are the different phases of medical coding? So usually we have three phases. One is abstraction. In this phase, the professional reads the complete record of patient to ascertain what condition the patient had, what caused it, how was it treated. To find out all this information, the medical coder uses clinical notes, laboratory and radiology reports, operation note follows. So basically abstraction means as a coder we need to read the whole documentation and we need to decide what are the things we need to consider for coding. So next one is assignment. In this phase, we will find the appropriate code for each procedure and enter into the system. So next one is review. This is a very important phase during which the medical coder checks if the assigned code set clearly explain what happened to the patient, how and how were they treated. So basically review is the final stage where we need to recheck and compare the services provided as well as our codes. The next question, there is a concept of undercoding and overcoding. Can you explain both? So basically undercoding is the purposeful reportage of less expensive medical services that are performed, while overcoding is the reportage of more expensive procedures that are performed. So both of these may be rated as fraudulent and can lead to an audits and investigation. These are not errors basically. So, but we are obliged to mention them. Here is something you absolutely must avoid. So we need to code based on the document as we can't code undercoding and we can't code overcoding. Based on the documentation, we need to code. So next question, have you heard about unbundling? What is that about? So like under and overcoding, unbundling is not so much of an error as it is a fraudulent practice. Unbundling is closely related to upcoding in that it involves false reporting designated to earn the provider higher payout from a payer. Unbundling means separately coding procedures that would normally be included in one umbrella code. So basically we have comprehensive code or component code in the CPT system. So along with comprehensive code, if the coder assigns component code which will comes under unbundling. Next question. What are the common modifiers used in the emergency department? Usually 25 and 27. So what is cerumen impaction? Cerumen impaction is condition in which earwax has become tightly packed in the external ear canal to the point that canal is blocked. So what is closure reduction and open reduction? So fracture reduced without incision is closure reduction and the one that is reduced with an incision is open reduction. Next question. Closed fracture is treated with open reduction. Is this true or not? Yes, it is treated with open reduction with internal fixation. So we have few scenarios here. So in a ED visit, patient not documented any critical care time, but patient diagnosed with acute respiratory failure and intubation performed by EDMD and patient admitted to observation. Report correct CPT codes for prophy and facility. For prophy, we will use 99285 and 25 31500, and for facility 99281, 25 and 31500. So basically, as per ACEP guidelines, when condition qualifies critical care, we can bill critical care services per facility without documentation of physician critical care time. And if RN documented critical care, also we can bill critical care services in facility side but not in professional side. So basically, critical care services we can code in facility but not on facility, sorry, professional side. So last and final question. A level 5 caveat patient presents to the ED for medical clearance. EDMD evaluated, then sent to psych hospital for admission. Lorazepam IV at 14 hours and hydration from 14 to 16 hours given in the ED. Physician has performed problem focused history, comprehensive exam, and high complexity medical decision making documented EMR, and clinical impression is depression with suicidal ideation. How do we code here? So for professional, we need to code 99285 depression code as well as R45851. For facility, we need to code 9928525 96374 as facility will provide services, and 96361 for hydration, and usual as usual ICD codes. Guys, we hope this session is very much useful for you guys. So if you need any other sessions, please mention in the comment section. Please subscribe, like, share, and comment in comment section. Thanks for watching Fast Coder 21.